Hello everyone, welcome to Healthline 3. I'm Terri Simmons. Today we're talking with Dr. Joseph Fredi of Willis Knighton Pierremont Cardiology about coronary heart disease. We'll be taking your calls throughout the show, and as a reminder, please make sure you're in a quiet room with your TV turned down to a very low volume or turned off, and when you call in so we can hear your questions. And the number to call is 318-219-4569, and you'll see it at the bottom of your screen throughout the show. Thank you so much for joining us, Dr. Fredi.
You're very welcome. It's a pleasure to be here.
Well, we are really happy to have you here, and I love talking about this topic because as I've been talking to you throughout the morning, I found a lot of things that we probably misunderstand about coronary heart disease. So what is it, first of all?
So coronary heart disease is disease of the arteries that bring blood to the heart muscle. So there are, for most people, 3 blood vessels that supply blood to the heart muscle, keep it going, keep it functioning, keep it pumping normally. And coronary heart disease is when those arteries become diseased, usually from a process called atherosclerosis, which is plaque buildup, and you can get severe blockage that develops in the heart arteries, and you can get to the point where it becomes completely blocked and can result in a heart attack.
Okay, and can it happen at any age, or is it more older?
Tends to increase with age. However, it can happen at any age. It depends on the risk factors, and that's something that we might hear about today. What are the risk factors for developing this process or this disease? Depends on the risk factors, and there are lots of other variables.
Okay, let's talk about that now. What are some of the risk factors?
So the risk factors are, number one, I always tell people, being an American. So
really?
Yeah, we probably have the highest risk factor profile possibly on the planet. Certainly we share that with other well-developed nations in the world. Interesting fact, it used to be that when somebody would move to the United States from an area where coronary heart disease was less prevalent, and decades ago, especially in Asia, Southeast Asia, Japan, it was much less prevalent. If a Japanese citizen would then emigrate to, say, Hawaii or the West Coast, which is not infrequent, within 7 years they assume the same risk factor profile as any other American. So being American, but the traditional risk factors are age, whether you have hypertension and how well it's controlled, how well controlled your cholesterol level is, what it is, how high it is, and whether it's controlled. Diabetes, a big risk factor, especially if it's uncontrolled diabetes. Smokers really increase the risk. And if you have a family history for this disease, especially if your immediate family members, parents, siblings, develop this disease at a young age, usually at an age less than 60 or 65 years of age, it really increases your risk. So there is a familial tendency for this in some populations.
Okay. So it's not only, like, as you said, being American, and as opposed to other places, is that because of lifestyle or surroundings?
So it is probably in part lifestyle. So, we drive everywhere, where if you were in Kenya and you lived as a Maasai, you would probably walk 10 or 15 or 20 miles in a day. And we tend to be, in this country, overweight. Obesity is a major epidemic problem in our country, and even in other well-developed nations. It's not as big a problem in developing nations, but it's becoming more of a problem as they become more quote westernized, if you will.
Right.
So,
yeah. Okay. Yeah. And so being here, we have a lot of those underlying conditions. We already know there is a lot of diabetes and other those conditions.
Yes.
Okay.
Absolutely.
And is there anything what causes heart disease that we can prevent?
Yes.
Or, yeah.
So I think recognizing your risk factors. So if you have hypertension, make sure that your hypertension is under good control. Mm-hmm. Number one, take your medicine. If you have a high cholesterol, talk to your doctor about whether it deserves treatment. There are ways to treat it, both non-pharmacologically, without medicines, and with medications. If you have diabetes, be sure to have it well controlled. If you are a diabetic, you should always know your last I'm going to throw this out, hemoglobin A1c number, just as much as you know your own Social Security number. And for the diabetics that are listening, your target hemoglobin A1c is 7 or less. Do not smoke. You know, it's terrible for not only for other things, but especially for your heart. Obviously, you can't change your DNA if you have a family history. But if you do have a really strong family history, you may want to talk to your primary care doctor about it. And there are ways of sort of assessing your risk factors and trying to modify them as much as possible. And finally, never underestimate the power of diet and exercise. It's very potent. And even if you were to develop coronary heart disease, if you do it in the face of a better diet and exercise, outcomes are better.
Mm-hmm. And that just seems the underlying no matter what. Everyone we talk to on Healthline 3, that's just the common thread of just watch what you eat and get as much exercise as you can, because movement in your day is movement in your life. You're going to feel healthier overall.
Right. And the exercise that we tell people is it's not like you have to become, you know, Arnold Schwarzenegger, right?
Right.
Walking 4 or 5, 6 days a week for 45 minutes or an hour is fine. I mean, you don't have to become a marathon runner. Just something like that is really beneficial.
Right, so it's just movement. Just getting up and walking more, parking a little farther from the door, little tricks you can do to just get more movement in your day. Doesn't mean work out to break a sweat, go to the gym. Just watch what you eat light, and move around.
Absolutely.
Okay. So tell us some more, like how is it diagnosed, first of all?
So how it's diagnosed is, the first thing is if you are having symptoms that worry you about whether you have this, you want to sit down and talk to a physician or even a cardiologist. To make the diagnosis, though, we have a number of tools available. You can have a stress test, an exercise stress test, and there are different types of exercise stress tests, but an exercise stress test is often very useful in making the diagnosis. There are ways of being able to image the heart arteries, the coronary arteries, by CT, what's called CT angiography, which in the last probably decade or even less than that has become much more accurate in being able to assess the presence of blockage in the heart arteries. But the gold standard is to have what's called a heart catheterization, which is where a cardiologist places a catheter in one of the blood vessels of your body. We usually use the radial artery in the wrist or the femoral artery in the leg, right at the upper groin area. And we pass a catheter, and we actually place this catheter in the arteries that bring blood to the heart, and use small amounts of X-ray dye and take a picture of the blood vessels as we're doing it. The thing to know about this procedure is it's not painful, and a heart catheterization done by an experienced cardiologist is actually safer than driving your car on an interstate highway. There are some risks, but they're very small. We always want to be sure when we advise an invasive procedure that we feel that the benefits of having that procedure done outweigh the risks.
And I'm so glad that we're saying this right here, because that does come up quite often with, it sounds like it would be so painful, especially when you describe what's really going on, but it's not a painful procedure, and it's done so often, and it's what you go to an experienced cardiologist who does this. It's, right, it definitely outweighs the risk.
Yeah, and we get a lot of information.
Yeah.
We first of all can confirm whether a person has severe blockage. Second of all, it is the best way to know what the best treatment options are for that patient. Not all coronary heart disease or blockages are equally treated. So the result of a heart catheterization in many ways helps dictate best therapy. And we can outline options for the patients and with the patient come up with what we feel is the best treatment plan.
And clearly to have all that, just see what's going on in there first. Just to clearly see what's going on gives you so much information.
Right.
So then you find a blockage, what's next?
So when you find a blockage, it depends on a number of things. One, how symptomatic is the patient? Is the patient having any symptoms, or are they having a lot of symptoms? So symptom status is really important. Second, how extensive so is it one blockage in one artery? Is it 7 blockages in all 3 of the blood vessels? And then finally, just like real estate where location is important, Where the blockage is in the heart arteries plays a lot, carries a lot of weight on what we recommend best therapy. And then finally, certain disease, so if you're a diabetic, for example, we know that there are certain options for diabetics that are better than others as far as treatment for coronary artery blockages or coronary heart disease. So there are a lot of things that go into it, but having the roadmap, if you will, is a big deal in being able to advise best therapy.
Definitely. And so tell us a little bit about the actual symptoms. What are the symptoms that we should look for?
This is where we might talk about symptoms vary a little bit.
Okay.
So the traditional symptoms is chest discomfort. And it's not always described as pain. In fact, it's often not really felt to be chest pain, because when people say, do you have chest pain, it's not like a knife stabbing you in the chest or something. It's often described as a heaviness or a tightness or a squeezing, sometimes sharper than that, but the traditional chest discomfort from coronary heart disease, which is called angina, is described for most people as tight, squeezing, heavy, sometimes burning discomfort. It's located usually in the center of the chest. It can be off on one side or the other. And then it can spread out. It can radiate, what we call radiate. And the traditional where it goes is the left arm, specifically the left inner part of the arm. And it can go all the way down to your hand, or it can just go part way down, or it doesn't have to radiate. It can be on the right side though. It'll radiate up the side of the neck, but the front part of the neck, what we call the anterior portion, up into the angle of the jaw. I've had patients present with it can actually involve your gums. I've had patients who came to me, but the only symptom they have is gum discomfort. They thought they were having a dental problem. If it radiates, spreads to the back, it's usually right in the middle of the back, between the shoulder blades, not off on one side or the other. It's associated with other symptoms. It's often accompanied by shortness of breath, sometimes sweating, sometimes nausea, and in severe cases, even vomiting. More often than not, it's associated with physical activity. So you may get it when you try to walk up a flight of stairs, walk up a hill, do some sort of vigorous activity, as opposed to just, sitting around and not exerting yourself. However, as it advances, then it also will start occurring at rest, even wake you up from sleep at night.
That was my question while you were talking. I was wondering, so it's not something that's constant?
It's not constant. Okay. It's usually, if it's constant, it's often a heart attack.
Yeah.
If you start having chest discomfort that doesn't go away, then be concerned that there's a possibility of having a heart attack. At which case, if you're really concerned about it, then the appropriate thing to do is call 911. People get embarrassed by going to an emergency room if they don't want to go there and be told nothing's wrong. Don't feel that way. We would rather have 100 people come and be told everything is okay than have one person stay at home and miss the opportunity to help that patient. This is, when people have heart attacks, time is muscle. So it is really important to try to get expeditious or timely care. We can stop heart attacks. We can spare heart muscle damage if we can get to it in time.
I'm so glad you brought that up, because we talk about a lot that too, and you and I were talking earlier too. It's okay. People are so afraid to call or to spend time asking questions or to go in. Don't be embarrassed. The best thing you can do is go in where you could be treated, and to hear you're fine, go home.
Yes, I would beg people never to be embarrassed about that. We would much rather have people be safe than the other way around.
Okay, and we talked too earlier about men and women. Are men more affected by coronary heart disease, or
they
women?
Are. So there's a change. So men, the big time periods for men that are affected, for most people, are for men probably in their mid 40s to mid 60s or even 70s. Women develop heart disease, coronary artery disease, at the same rate as men. It's just delayed a little bit by about 10 years, the peak of it. It's felt that the delay is probably due to the beneficial effects of estrogen on coronary arteries, and as women go through menopause, then their risk factor profile changes. We talked earlier that when women develop heart disease, their outcomes generally are outcomes may not be as good as men even with treatment. That's just, the reasons are not entirely clear, but study after study after study comparing outcomes in men and women have borne this out.
I remember hearing, it's so interesting that you brought this up, I remember reading and hearing years ago when they first started seeing that women will deny it longer. It'll just go on. And plus the jaw discomfort, hearing that could be something that women just keep going and they don't think about it.
And the other thing about women is that their symptoms sometimes are less, they sometimes are not the classic symptoms, and if anything, one should have a sort of a lower threshold for being suspicious. So women sometimes will only be they won't have traditional chest discomfort like is been described. They may only have shortness of breath, especially with exertion, and a lot of fatigue. Sometimes that's the only symptom in women for the tip-off that maybe they have coronary heart disease.
Well, that's very interesting to point out to our viewers, anyone watching. Fatigue, pay attention to that. Sometimes people think, especially if you have underlying conditions.
Right, if you have risk factors, then pay attention, like you said.
Pay attention. Yeah, that fatigue is telling you something.
It is.
And don't be afraid to call your doctor.
Right.
And find out.
Yeah.
Okay. So tell us about a stress test. What does that really mean? What happens during a stress test?
So we use it in EKG a lot to help us make this diagnosis, and a stress test is done several ways. So what we try to do, we mentioned before that people will often have the symptom when they exert themselves and not at rest, at least early on when they first develop it. A stress test does that. So you stress the heart out, you increase the heart rate. We want to increase the heart rate to almost what the maximum heart rate is. Somebody's maximum heart rate is their 220 minus their age. That's about as high as your heart rate can get. We want to get to about 85% of the predicted maximum heart rate in order to get a diagnostic stress test. We put people on the treadmill, we hook them up to an EKG, we have them do what's called a graded exercise study. So every 3 minutes the treadmill goes higher and faster until you get your heart rate to whatever level it is for your age that would be diagnostic. And we look to see if there's any EKG changes as you're exercising that may be the tip-off for the diagnosis of a possible blockage. We also have means of being able to actually image the heart as well. There are ways that we can give medications to people through an IV during a stress, both before and during a stress test, and looking at blood flow patterns through the heart as well.
Wow. Yeah.
And these are all non-invasive tests that can help us arrive at whether somebody might have that diagnosis.
Okay. And we talked about, and you would ask for a stress test when they're having symptoms. Is there any other reason that you would ask for a stress test?
Sure. There are lots of different reasons for a stress test. Sometimes we use a stress test to see if our medical treatment for them is adequate. We have people who are in high-risk occupations that have to have stress tests in order to be able to continue their occupation. If you're a Navy SEAL, for example, you may need a stress test. If you're gonna join the fire department or the police department, you're a public service, officer. If you're, depends on your occupation sometimes. So, but the most common use for a stress test is for diagnostic purposes.
Okay. And we talk about damage, or we talk about maybe the effects that accumulate. Can it be reversed?
No, generally not. It can be, and I want to say generally not. So when we're talking about coronary heart disease, damage occurs from a heart attack. If we can get the blood vessel open within 90 minutes of the development of symptoms, we can often spare a lot of heart muscle damage. Even minimize the heart muscle, really minimize. Interestingly, despite the blockage that can develop in heart arteries, the prognosis, so how well a person does, how long they're going to live, how well they're going to feel, doesn't necessarily depend on how many blockages they have. It depends on how well their heart muscle continues to function. If you can maintain normal heart muscle function despite blockages, because we can treat blockages almost always, not always, but almost always. But if your heart muscle function can remain normal, then the prognosis remains very favorable and very good. And the quality of life remains quite good too.
Okay, so once the heart is damaged,
Once the heart is damaged from a heart attack, it's difficult to restore that. Now we have ways of being able to treat with medication that can help, and there's some other things that can occur. But you generally, once the heart muscle is damaged, it's gonna be damaged. Then we're dealing with transitioning from somebody with coronary heart disease to somebody with coronary heart disease and potentially congestive heart failure.
Okay. And you talked about the different therapies someone might have as far as how much blockage they actually have. Do you want to talk a little bit about that?
Yeah.
The difference
So we
in
have three ways of treating coronary heart disease. One way is with medicine. We know there are some medications that can help. Medicines don't make the blockage go away, but medicines can help relieve the symptoms. The value of a heart catheterization is to determine how risky is that blockage. Is that blockage risking a lot of heart muscle if it were to block off, or is it just a little bit of heart muscle? Because you can't distinguish that based on symptoms alone, right? So we often will use a coronary cath result to be able to advise whether medical therapy should be adequate. Second way we have is to relieve the blockage by putting in a stent. And I think most people know what that is.
Yes.
It's an angioplasty and putting in a stent. Excellent procedure, excellent results. Modern day stents have excellent outcomes. And the third way is with coronary artery bypass surgery. So there are certain specific situations that are advantageous for each one of those options, and the results of the cath in consultation with your cardiologist can go over the pros and cons of each approach and hopefully arrive at a best decision.
Okay. And if someone doesn't know what a stent is, can you describe that procedure, what it means?
Yes, great question. So a stent is a little device that we can insert inside the heart arteries in order to relieve a blockage and eliminate the blockage, not eliminate a little bit of the blockage. We're talking about all of the blockage. Stents are generally made of very small, the best way for me to think about it is that, I don't know if now, but I haven't taken a ballpoint pen apart in a long time, but you know that little spring? That's right. So it's a little bit like that. It looks a little bit like that. It really looks, it's less metal, okay? And the stents, now the Achilles heel of stenting when it was first developed in the 90s was that scar tissue would reblock the stent over a period of time for some patients. Now we have stents that have medication on the outer surface of the stent that inhibits that scar tissue formation. So in fact, stents are very durable, and a very good option for many patients.
And does the stent stay, or is it removed?
It stays forever.
Okay.
Yes.
And this medication just stays forever?
The medication will slowly elute off the stent over a period of 12 months usually. Once a stent is there and you have no problems after a year, it's unlikely that stent will ever become an issue again for most patients. Not a guarantee, but less likely.
Okay. And if you have, that's obviously if you have blockage in one area, that goes in there, and then you can develop blockage though in other areas later.
Oh, absolutely.
Right? Okay.
Absolutely. So if you had a stent put in one spot today and you do well for 10 years and develop symptoms 10 years later, more likely than not, it's new blockage. Not always, but more likely than not. Okay. Again, a heart cath would have to be done in order to be able to sort all that out.
Okay. Get that in there and see what's going on. And so say I get diagnosed with coronary heart disease and I'm like, okay, I'm done. I'm really going to shape up completely. I do a whole turnabout and really start living my life in a different way, very, very, very healthy. Is there anything that's doing too drastic too fast? Do I need to ease into a new lifestyle and take care of my heart in any certain way? Is there any difference in taking care of yourself once you're diagnosed with something?
Yeah. I don't know that you can do too drastic too fast in this. I saw a patient in the office yesterday who told me that they were going to stop smoking, but their primary care doctor advised that they do it slowly because it would be too much of a shock to the system. It was like, what? Are you kidding? No, just stop, just stop. No. So I don't think you can do too much too fast. What you want to do though is find a sustainable lifestyle change, because you know, like most people, where after something happens, we're all enthusiastic to make all these changes. And sometimes the changes we make are just not sustainable. So find something that you can really sustain over a period of many years, even decades.
That probably would have been a better way for me to ask that question too, to not jump and overload and think you're going to change everything right away because you're scared and you want to take care of your heart. So you do just have this big plan, and then you can't sustain it. It's not something that fits your lifestyle. So in that way, take it easy.
I think you're right. It's a great question. I think you're right. While you may be able to not do it, you know, too much too fast, it may impact your lifestyle so much that you actually give up on it.
Yes.
And that's what you don't want to do. So I'd rather somebody make a small to moderate change that's sustainable than make a drastic change that they give up on in a short period of time.
Yeah. And is that wear and tear on your heart? So you go full strong, your heart's pumping like crazy, you do this for a few months, and then you just stop and starting. Does that hurt your heart
probably,
as well?
I don't know of any data that suggests that's detrimental to your heart, but we do know that having a sedentary lifestyle is not beneficial to your heart, so and in fact may in fact be detrimental.
Okay, so that's really it is. Doing nothing is the thing. Don't think you're protecting your heart because you don't want to do too much.
Right.
It's a muscle.
Yeah, you're not going to do so much to damage your heart.
Okay. And what are some of the questions that you do get, like our viewers now, and there's still time to call in if someone wants to ask doctor something directly. What kind of questions do you get asked? Someone have, and what should they maybe document before they what information can they bring in to talk to you that you might ask them so that they're ready to answer questions if they're having symptoms or?
Yeah, so you know, we go over symptoms and we try to make an assessment of whether we think their symptoms are truly from heart artery blockage. We call that angina. A lot of questions I get are a lot of questions about lifestyle and diet. Lifestyle and diet, you know, should I quit my job? Is it too stressful? Things like that.
Okay. And it's a good thing probably to let people know too, it's not about shaming yourself. If you go to a doctor and the doctor says, well, we can do a lot of this improving just by your diet and your exercise, to kind of take that as a positive thing. It's kind of good to hear that that's all you might need to do with no treatment yet. Let's work on that first.
So that it's always good to have options, right? So it's you know, it's a no judgment zone. We do not live in a judgment zone. We in the healthcare profession are there to try to help people live healthier lives. It is not about judgment at all.
Not at all, and that's a good thing that I like to talk about. Well, I think Healthline 3 is so helpful when we get to talk to you, just like I'm sitting here in your office and asking things that it's fine. It doesn't matter. Just ask the questions and ask you. You're the source of information for us.
Yeah, there are, like your school teacher said, there are no dumb questions. No dumb questions. Right.
Yeah, nothing wrong. So is there anything else that you'd like to say to leave us with today? This has been so informative. Thank you so much.
Well, you know, again, I just want to emphasize that coronary heart disease is a leading cause of death in all Americans. We are all susceptible for the development of coronary heart disease. Know your risk factors. As best as possible, know what you can do to minimize your risk, and then most importantly, if you begin having symptoms, do not delay going to see your doctor. And if you have enough risk factors, have the conversation with your doctor. You know, doctor, I have 4 risk factors for heart artery disease. Should I be checked? Do I need to be checked? What should I do differently?
And those are great questions. And just listen, what can I do differently? Take the information and bring the information to you. So like say I am having angina, write down maybe what I was doing before I had it, or kind of document kind of how it's happening to me and bring as much information to you when we talk.
Right, and when we sit down with somebody and talk to them, we try to sort all that, we get that out of them.
Okay. Well,
we try to.
Okay, try to, yeah. Well, once again, this has been so informative. Thank you so much.
Thank you for the opportunity.
Oh, it's been just lovely, and it's so valuable. I know our viewers really appreciate hearing all of this and busting the myths about men and women and who gets it and what to do to be diagnosed. So we look forward to talking to you again. Thank you.
Very welcome. Thank you.
All right, sure. And enjoy your afternoon.
Thank you, you too.
And thanks. And everyone, thank you again so much for joining us for Healthline 3. We really appreciate you being here. You enjoy your afternoon, and we'll see you next time on Healthline 3.